We're going to talk about irritable bowel syndrome, just a summary overview of what we're going to be talking about. We're going to show how irritable bowel syndrome is a disorder of gut-brain interaction. It manifests itself as a recurrent abdominal pain and some altered bowel habits as well. We've structured the talk into three main components. We'll start with the background, go into a little bit of some evaluation, and then conclude with some management strategies. The first section, we'll see how IBS is very common. It's also quite costly and associated with a pretty significant symptom burden. But interestingly, there are several individuals who don't seek any medical attention or evaluation at all for further management. We'll also explore the evolution of irritable bowel syndrome in terms of how it's defined and kind of how we got to that definition, where the current paradigm is the Rome criteria and does focus specifically on the abdominal pain and its association with the change in bowel habits. And then in terms of when we move on to the evaluation component, we'll see how things have shifted to a more positive diagnostic strategy, meaning that how we think about IBS, it's no longer necessarily, okay, we've tried to work up for a whole bunch of potential structural lesions or causes for some of these bowel symptoms. We've got more of this criteria of meeting the symptoms, and that's qualifying for irritable bowel syndrome. But we still do want to rule out several other diseases that can have similar symptoms. So there are still several tests that, if we do want to work this up, your doctor will probably have you evaluated for. And then we'll conclude with some management strategies. There's quite a few options on the market right now. So there are a lot of discussions that if we are thinking about treatment, that things do get individualized to the patient. So the best option isn't necessarily one size fits all. It really depends on what some of the dominant symptoms are. And there is a whole variety of things on the market, ranging from prescription drugs to dietary modification to different psychotherapies or supplementation as well, that folks find helpful. We'll start by delving into the background of it. So the condition of irritable bowel syndrome, it's been defined by actually a little bit of an evolving symptom set. So the definition in the past may be a little bit different than how it's defined today. And then the leading organization that comes up with the definition of irritable bowel syndrome today is the Rome Foundation. But the disease and its symptoms date back several hundred years, with early descriptions talking about when patients have bowels that are sometimes constipated, sometimes some diarrhea in the same person. They just don't have a good idea of what was necessarily causing the symptoms. They can't find anything, and that's thought to be some of the early descriptions of irritable bowel syndrome. And largely it functioned as a diagnosis of exclusion, meaning, okay, we can't find any other cause for some of these GI complaints. So then this is kind of what we're left with. And then around the 1970s, things started to change a little bit. There was more of a push to, instead of just having this, you can't find anything, this is the diagnosis, to have a more structured approach that these symptoms are pretty consistent across patients and then do make up this disease category. And then there's a lot of talk about how, in terms of now with this definition, a key component of making a diagnosis is more in terms of the history, the conversation one is having between themselves and the doctor, and not necessarily just ordering a lot of tests to rule out a whole bunch of other potential causes of the symptoms. And then in the late 1980s, the Rome criteria became one of the major organizations or foundations to help formalize this whole symptom-based approach to diagnosis. It's gone through a few revisions. The most recent one was in 2016, but there is a new one that will be released in a few months this year. So there may be some slight changes to it, but the most recent definition does define irritable bowel syndrome as recurrent abdominal pain on average at least 1 day per week in the last 3 months, associated with two more of the following criteria, which include related to defecation, associated with a change in frequency of stool, also in the form or the appearance of stool. So this is kind of the gold standard diagnostic criteria in terms of thinking about irritable bowel syndrome. And then, as we've said a few times, it is relatively common, but many individuals may not visit a physician for evaluation. Using the most recent Rome criteria, the estimate of number of adults in the United States is 6% in terms of who have irritable bowel syndrome or report the symptoms. Depending on the criteria, these estimates range anywhere close to upwards to 10% with some of the older versions of the criteria. And this is in line with other pretty big chronic conditions such as asthma, because that's also about 8% in the United States, and roughly half of the number of folks with diabetes, which is at 12%. And then in terms of thinking about the people who more commonly report symptoms, a lot of the epidemiological studies do suggest that women more commonly report irritable bowel syndrome symptoms than men. And despite being the condition most responsible for visits to a gastroenterologist and one of the more frequent conditions in the primary care setting as well, when they do some online symptom surveys, they note that up to 75% of individuals, even if they have all the symptoms meeting the criteria, don't necessarily see a doctor for further evaluation and management of it. And I think part of that may be due to the spectrum of of symptoms folks with IBS have. On the surface, it may appear relatively benign, especially if some of the symptoms are mild, but it can definitely seriously affect an individual's quality of life. There's a few things that folks have noted in terms of some of the financial toxicity or the expenses associated with IBS. It does lead to individuals going to the doctor more, thinking about therapy. So there is an element of financial cost that folks have to contend with that is more than folks without it. And it can range from the several thousands of dollars per year, depending on how severe the symptoms are and various insurance plans and stuff like that. And then it's also things that are maybe a little bit more difficult to measure too, that folks with IBS find they have to take more time off from work due to their symptoms. And then even at work, they feel like they're less productive as well due to their symptoms. And some of the academic terms for this is absenteeism is not being at work, and it's up to about a quarter of patients report having to go down that pathway. And then the vast majority, 87%, report presenteeism, which is essentially coming to work, but then the symptoms are just too bad, so they can't really function as well as they would like at the job. So pretty significant in terms of the disease burden itself. There's been this continued quest what exactly causes irritable bowel syndrome. There's a whole lot of theories, hypotheses out there. They all have varying degrees of evidence. People have speculated things like gravity, nervous system dysfunction. You've got SIBO, like bacterial overgrowth in the small intestine contributes. There's different kind of malabsorption of different bile acids. After GI infections, there's maybe a variant of irritable bowel syndrome. There can be changes in the gut microbiome. There can be genetics. There can be environmental factors. There could be dietary factors as well. So there's a whole bunch of different theories about what actually causes irritable bowel syndrome. So we just picked some SIBO, gravity, the nervous system, and then the post-infectious categories to take a little bit of a deeper dive into today. It's quite a complicated slide here, but this is just looking at the neurobiology, how a lot of those factors contribute to irritable bowel syndrome, because it is classified as a disorder of kind of gut-brain interaction. So here this figure is showing a lot of those pathways between the brain and the gut, and then looking at different factors along that axis that impact the symptoms. With the yellow lines, you can see they found different sex differences, different genes that may alter the relationship between the brain and the gut and lead to irritable bowel syndrome. There's also kind of loop with the microbiome that affects kind of how the nervous system and signals are being sent between the two. And then in the center, there's different immune risk factors in terms of infections and inflammation and different neurotransmitters and signaling that's all going on there. And then on the purple pathway, you can see how there's environmental stresses, and those kind of can both impact the axis. And then in the center figure here, it goes into a lot of granular detail that we don't have to delve into, but you can see down below, you get all these kind of microbiota, metabolites, short-chain fatty acids, all these things in the gut. And then you've got the layer, the barrier of cells between the gut and the rest of the body, and there's kind of various interactions these molecules can have with the gut through various pathways along the nervous system that ultimately make their way all the way up to the brain, and then through the brain can signal back down to lead to some of the symptoms. So this is one of the reasons it's classified as a disorder of gut-brain interactions. There's just a whole lot of signaling between the two and a lot that can go wrong in those pathways. And then here, this is a little bit more newer of a theory in terms of what contributes to irritable bowel syndrome. We can focus a little bit on the GI specific column on the left in terms of how gravity may contribute. The hypothesis is as humans evolved, the body had to essentially develop more of a infrastructure to properly keep the bowels suspended and oriented in the body. And they found in terms of folks who may have higher risk of having irritable bowel syndrome, there may be more things like laxity in terms of the bowels, kind of longer colon and stuff like that. And it's hypothesized that a lot of these things may happen if the body is not kind of best accommodated to resist the force of gravity. And when those structures are not maintained, if there's any weakness or issues in development, the gut may stretch out, may expand more. With some of those changes in terms of stretch, a lot of the nerves and everything will start firing and signaling a little bit more. Normally we get the symptoms like the abdominal pain, some cramping, some bloating in terms of detecting that distension. And then that as the bowels distend a little bit more, it kind of alters a little bit of the motility of the gut, and that creates opportunity for some bacterial overgrowth, for gas, for pressure, and immune dysfunction. So it's another interesting theory that folks are working with in terms of thinking about the etiology of irritable bowel syndrome. And then another notable subset is this post-infectious irritable bowel syndrome. It's come from a lot of observations, as we see in this graph here. So this is looking at the number of people who have irritable bowel syndrome in relationship to after a GI infection. And generally, in the couple couple of years following the infection, there is an increased number of people who are reporting symptoms consistent with irritable bowel syndrome. And this has been shown across quite a few studies. And they've even looked into mechanistically what happens. And it's essentially when the immune system is originally targeting the infection, there are some antibodies that help target the infection, but then at the same time, there is a little bit of some overlap with what those antibodies are targeting in your own immune system. So there are some cells in the GI tract that these kind of similar antibodies will attack, and then some of that inflammation and destruction leads to some of the irritable bowel syndrome symptoms. It's one of the more studied with a clear biological mechanism of how we're getting to these symptoms beyond more of these kind of bigger theories with a lot of moving pieces.
Is COVID something that you've seen IBS symptoms? I know that's not the primary thing that people have with COVID, but they can have gastroenterological symptoms.
So you've definitely seen post-COVID, a decent number of people have developed the symptoms. I haven't seen it necessarily linking the same pathway. Some people with COVID do have specific kind of like GI symptoms, so I feel like it could be related to this. I haven't seen the literature specifically looking at this pathway, but I think it's similar with the immune system being a little bit dysregulated and then it attacking the own body instead of just what's going wrong. So I think it's definitely a very interesting pathway and could be very plausible. Another one too is SIBO and bacterial overgrowth in relationship to irritable bowel syndrome. Because some studies have noted a lot of folks with irritable bowel syndrome, close to 80%, have bacterial overgrowth. Other studies, what we're seeing with this table here is when we essentially treat SIBO in folks with irritable bowel syndrome, the irritable bowel syndrome symptoms all improve. So we can see in the little bit of the columns more on the left side, when we're not treating SIBO and irritable bowel syndrome, in terms of the p-value, looking at like the significant reduction in any of the big symptoms like bloating, diarrhea, abdominal pain, nothing is significant. There's not a major decrease. But then when you treat SIBO in folks with irritable bowel syndrome, we do see improvement in the diarrhea and the abdominal pain aspects of it. So there's this question of what exactly is the relationship between the two, but there is a good overlap and folks do respond well generally to the treatment for SIBO, which is usually just a course of antibiotics for a little while to help treat the symptoms. Then it is a little bit of the chicken and egg. The question is if there is some underlying IBS or kind of motility issue that things aren't moving along, you are predisposed to developing bacterial overgrowth again. So folks may have to go through several courses of the antibiotics to see if there's anything else that can be done to address the underlying motility of the gut. Otherwise, we have to keep treating the symptoms. So we talked about all these potential causes, these theories of what's contributing to IBS. So while they're trying to have some unifying understanding, there's also a school of thought that maybe what we should be thinking about a little bit more is this idea of undiagnosing IBS. Are they really all these subsets or different actual kind of conditions that we just aren't aware of yet? In some of the evidence that they point to, there's certain biomarkers that can be looked at and they're elevated in some subsets of irritable bowel syndrome, but not others. And they're like, if there's these different pathways, there's different kind of biochemical responses. Maybe they're separate diseases entirely. And I think a big one for that is a little bit, we're talking about the post-infectious course. Because in those cases, kind of those antibodies, they can specifically look at the blood for them. There are these anti-CD/TBB and these anti-vinculin antibodies. They are elevated in the post-infectious IBS, specifically kind of diarrhea subgroup. And then the levels do improve with time with treatment and symptoms. So there is a thought that the biological pathways related to these, but then there are other subsets of irritable bowel syndrome that these antibodies aren't elevated, but the symptoms are still there. So maybe something else is going on here, and this is a little sub-segment. And then there's been a lot in terms of kind of bile acid diarrhea can mimic a lot of irritable bowel syndrome, and that's now pulled out of it, and there's different stool studies for that. So there's some folks out there who are trying to stratify within irritable bowel syndrome, some disorders out there. If you are having these symptoms, you want to get them evaluated, you want to go to the doctor, what are they going to start with or do when you go have your conversation with them? Honestly, the workup is quite varied, and the doctor may have a discussion, what's their predominant symptom? Is it kind of more bloating, more pain? And then they definitely want to rule out things that can have a lot of the similar symptoms of irritable bowel syndrome. We talked a little bit about the bacterial overgrowth or the SIBO, and there's kind of intestinal microbial overgrowth, all these other things. They could do different breath testing maybe if there's a lot of bloating or symptoms that kind of overline with that diagnosis that they may set you up for. In terms of infections, it's not just the post-infections, but the actual infections themselves can cause these symptoms. And one of them is giardiasis. So there's different stool studies that they can send to look for evidence of this infection. If there are other symptoms, like you feel like your heart's racing, sweating, there may be things like more kind of endocrine or hormonal. So they can also do blood tests looking at thyroid that may see if there are any kind of hormonal causes to the symptoms. And then there's immune-driven diseases like the inflammatory bowel disease. And there's different both blood markers for inflammation like the ESR, CRP, and also some stool studies that can look for evidence of this disease and ultimately maybe have to go for colonoscopy too to rule that out. Sometimes even things like lactose intolerance can cause similar symptoms. So if food diarrhea isn't helping elucidate that, they can also do different breath testing for that. Other infections, more stool studies they can look at. Other autoimmune things like microscopic colitis can also do colonoscopy. Some celiac stuff can also do some blood tests. There's a lot of potential conditions that may present with similar symptoms to irritable bowel syndrome that are worth looking out and making sure kind of we don't have, because the treatment would be different if these do surface in the workup. Because there's so many potential mimics, potential things that could be related to this, it may feel like there's an extensive set of tests because some of them also are shown that the yield of them finding anything is pretty low. So here on these graphs, we can talk about the one with the colorectal cancer on the left first. You can see the IBS, the folks with IBS are represented by the black line, and people similar in age are represented by the yellow line. But you see that even though folks who are presenting with IBS symptoms, there may be a concern about colorectal cancer, they undergo colonoscopy. The actual risk of finding it, as we can see, because the black line is lower than the yellow one, is actually lower than the general population. And then celiac disease has a similar trend earlier on in life. When we get past maybe age 60, 70, the lines intersect a little bit and it changes. But still, when you look at the estimated risk overall for celiac, it is 2 to 4%, so it's not the highest. So a lot of these authors of these studies have concluded that a lot of alternate diseases like the inflammatory bowel disease, cancer, celiac disease are relatively less common in irritable bowel syndrome, and the yield of doing endoscopy and some of the more kind of invasive studies is low for a first-time diagnosis of irritable bowel syndrome. Definitely if the symptoms are going on for some time, we're getting kind of later on in life, the utility of some of these tests is a little bit higher. The risk is maybe lower, but it's still not zero. So it may be worth doing depending on the conversation you're having with the doctor and some of the symptoms you're having. Because people with irritable bowel syndrome are still at risk for having other conditions. Looking at similar graphs, some that are seen as more common are microscopic colitis later in life. Here, the irritable bowel syndrome in the black is higher estimated risk than the population. And then for inflammatory bowel disease, it's usually kind of a low incidence overall. If you look at the chart on the right for inflammatory bowel disease, it's like just less than 2%. So they're saying that the risk of finding these is low, but still folks with irritable bowel syndrome, the risk is still higher. And if you look at it for inflammatory bowel disease, the risk in the regular population is 0.5 and it's 2% on irritable bowel syndrome. That's 4 times what the rest of the group have. So it could still be worth taking a look at things if we're still not getting good response to either treating for irritable bowel syndrome or the symptoms are persistent for a while, or there's some other kind of more alarming signs that pop up in the evaluation. The tests we talked about so far, those are largely standard. Most doctors order them. They are some kind of more niche tests. Insurance may not cover them. They may be expensive, but just for reference, we talked about the biomarkers for the post-infectious bowel syndrome. They are tests that actually kind of look at these antibodies, and some folks find them helpful because it helps confirm, okay, it is this post-infectious. It was due to this episode I had. Sometimes we can monitor these antibodies over time, see if the treatments are effective in terms of guiding how we're managing it. But it is usually pretty specialized gastroenterologists who start thinking about some of these tests. We just talked about breath testing in case some folks may not be most familiar with it because it's not necessarily all these like blood tests or stool tests that are commonly ordered as other kind of diagnostic things. Sometimes there are things to do at the doctor's office where you may take some sort of sugar or something and then they'll monitor the gases in your breath at various intervals. So it's not necessarily quick and easy because there's some time period for monitoring these gases. The figure at the left, some of the key ones they look at are the hydrogen, which we may see more if it's a diarrhea picture with irritable bowel syndrome. The methane is usually more of a constipation picture with irritable bowel syndrome. But also in this photo here, there are different breath tests you can do at home. So some folks, if it's covered, they can do some at-home breath tests too, which some folks find a little bit easier to do than coming into the doctor's office to do those for a while. So now you've gone through a lot of these tests, you've reached the diagnosis. The question is what's going to go next. And honestly, it's pretty individualized, but there are a few things out there. It's largely going to be a conversation you have with your doctor about this, because there are things like some people feel like supplements are very helpful, these non-prescription therapies. In terms of supplements, peppermint oil is thought to be one of the most studied one. It's thought to act as some kind of the muscle relaxant mechanisms. But then there's also different over-the-counter laxatives and anti-diarrheals, depending on if you're having more diarrhea versus more constipation, that can help with the symptoms. And then in terms of dietary interventions, there's the low FODMAP diet and soluble fiber. There's a whole bunch of prescription medications, which we won't get into today because there's a whole bunch of them that can target the motility, can target the pain, and all these things that, depending on your response to other medications, the doctor may explore. There's also various psychological therapies like breathing exercise, meditations that folks sometimes respond to. And then just some lifestyle modifications too have been shown to help. Physical activity itself, exercise has been shown to improve symptoms, sleep optimization, stress reduction. It can be really targeted from a whole bunch of different modalities. I think that reflects what we're talking about earlier in terms of trying to really understand what the root causes of it are. There can be a whole bunch of things contributing. So you've got a whole bunch of different therapies that we can try to help out. Just delving into a little bit about fiber, because folks sometimes seem to have questions because there's different types of fiber, a whole bunch of different things out there that in some cases they may worsen things, sometimes they may improve. So just to give a little bit overview of the different types, the soluble fiber, some folks with IBS seem to have found more effective, largely because it forms this kind of like gel-like substance that may coat the lining of the GI tract, but is found in a lot of fruits and vegetables. So incorporating that in the diet can definitely help with this, can do some supplements if needed. And then there's this insoluble fiber, which is more kind of bulk stool forming kind of fiber, and it's found in a lot of grains and in cereals and stuff like that. But it is a little bit of a balance because if there is a little too much, it can cause some more gas, some bloating, distension, which are all the symptoms of the irritable bowel syndrome. So finding that sweet spot is key here. And then there's the low FODMAP diet, which is talked about a lot. It stands for FODMAP, the fermentable oligosaccharides, disaccharide, monosaccharides, and polyol diets. These are all different types of carbohydrates. They aren't well absorbed in the gut, so they can drive water going into the gut, can grow bacteria growing there, and can cause a lot of the symptoms of irritable bowel syndrome. So on the right, we just have a list of if we were going on this diet, what it may look like. In the red are the high FODMAP foods that we want to avoid. In the green are the low FODMAP ones that we want. In terms of vegetables, carrots, cucumbers, lettuce is pretty good. And fruits, kiwi fruit is, I think, the one people generally find the most helpful, but there's also cantaloupe, pineapple. For dairy, almond milk, feta cheese can be helpful, and there's a whole bunch of other different foods you can look into more. So just to review and summarize and bring it all home, as we talked about today, IBS is gut-brain interaction. Main symptoms are abdominal pain associated with some altered bowel habits. It's common, high symptom burden, but some folks it is a spectrum of symptoms. Some folks feel like they can manage it on its own, so a majority actually don't see the doctor. But if you were to go to the doctor, there are a lot of blood tests, stool tests, even breath tests, or some other tests they can do to make sure there isn't anything else that may be causing these symptoms. So it's worth getting checked out, because depending on what they find in their workup, they can really tailor a treatment plan, counsel on different either dietary, psychological, prescription medications to help the symptoms and help you guys feeling better.
I've always been curious about the FODMAP diet and what it stood for, and it makes me feel better to know that it stands for something very complicated that I couldn't remember if I tried.
Yeah.
And a note on that too, just as with all diets, that's a diet that you might do specifically if you have IBS symptoms. If you're not somebody that experiences IBS, that might not be the right kind. So don't think that because something's in the high FODMAP, it's something you shouldn't eat. This is just a specific diet for specific symptoms. Just throwing that out there. You might miss out on some variation in food choices. It's a tool that can help with this in some ways, but if it's not something you're experiencing, then it's not a diet that you have to follow. If you've had another infection that you can later on develop IBS, is C. diff one of those infections that you can see IBS being a later development?
So in terms of the infections, when we see that, I think it's most commonly seen in things like Campylobacter infection, or like food poisoning scenarios is the most common and the most well studied. With C. diff, it's still little similar in terms of you are having the immune system and the gut involved. I think it's probably not as well studied and not like the typical kind of setting where this has been shown, because I think it's usually some sort of kind of food poisoning, get some kind of diarrhea, you recover from that, and that's a more traditional way. Some of the theories are specifically related to the way these organisms and the antibodies to those specific organisms work in terms of how the symptoms develop. But we've seen a variety of GI infections. People afterwards do develop symptoms, so it definitely could potentially be a source. There's a concern like antibiotics themselves may alter the gut microbiome, and that may lead to the symptoms. There's a lot going on with the whole C. diff developing those conditions that alter the GI tract, and that can eventually probably lead to irritable bowel syndrome.
What is the difference between irritable bowel syndrome and irritable bowel disease? So IBS and IBD.
Inflammatory bowel disease. They're very similar acronyms. What they see when they look at biopsies, like they actually look at like the inflammatory process in the colon. In terms of the whole like biological and inflammatory pathway, it's a lot more active autoimmune stuff going on in the time. So that's why when we think about treating it, it's a lot more things like steroids or immune suppressing agents, because it's more of the body's immune system actively in real time attacking the colon. It's more the IBD, inflammatory bowel disease, whereas irritable bowel syndrome, when you look at the colon under the microscope, you're not seeing that active self-destruction. There's still the immune system through other antibodies and things, but you don't see when you take that biopsy the actual active destruction of the cell. So it's that kind of organic, and I guess they do call it the organic disease for lack of a better word, but essentially when they take samples of the colon, it's going to look different under a microscope due to the different way the immune system is.
Is there a certain age at which people usually get diagnosed with IBS?
Definitely see it across the board. I think probably the most common people I feel like coming in maybe like in their 40s. I don't know if that's just because at that age we start being more aware of things. We've tried some things ourselves and not had success, so we're seeing the doctor. But I feel like people come in at all sorts of ages.